So people are aware that the governor put out reopening plans for a number of different industries, including healthcare. That was last week. And essentially, it sets up a set of criteria that the hospitals have to meet. So first is a state criteria, how much bed availability is in the entire state of Massachusetts. And once that was fundamentally reached, then the hospitals can look at their individual criteria. And the state already said that the baseline criteria of 30% bed availability was met in the entire state. So now it leaves it to the individual hospitals. So the hospitals are supposed to have ICU beds, 25% availability of ICU beds, and that includes surge beds. So if they've designated a unit to have additional ICU beds as a surge capacity, they can include that in the number of 25%, but they have to be able to staff that surge beds capacity within 12 to 24 hours if they're going to include it. So you need 25% of those ICU beds available. And then in addition to that, you need 25%, or I shouldn't say in addition to, also you need 25% total adult bed capacity in the institution. So that would include the ICU beds, but 25% total adult beds as well, including those surge, if you can staff them within 12 to 24 hours. That's a baseline criteria. Then there's a lot of smaller criteria, or I shouldn't say less important, but additional criteria, making sure that you have 14 days of PPE on hand at all times and a mechanism to be able to replenish that supply. You have to have criteria in place in order to be able to assess patients as they enter the building. That includes whether or not they're coming in for planned or unplanned admissions. You have to have a set of policies in place with regard to visitation, and it's recommended from the Department of Public Health not to actually expand the visitation, I think, beyond where we were, which is pretty limited, for maternity, generally a companion, for pediatric, one other person, for end-of-life issues, one to possibly two people, and then no matter what, when people come in, they have to be in full PPE as well, one at a time. Generally 15 minutes, the limitation. There might be some variation of this, but that's sort of the general look at the visitation. And there's really not much of a desire right now to expand it beyond that at this point, even though it's hard, because we just don't want to see the increase of COVID patient transmission by visitors or to visitors. Also, sanitation practices, a cleaning protocol on how that's done. Signage throughout the institution, clearly people wearing masks throughout, regardless of whether or not they're in taking care of patients at a minimum cloth or surgical mask, 6-foot distancing, same as it would be outside of a hospital setting. All of those criteria have to be in place as well in order to be able to restart. Yes, it's actually a good question. And when I said the 25% of bed availability, particularly in the ICUs, if you're going to do that, if you say, yes, I have 25% of bed availability with staff, that means that you have to have staffed it according to ICU law and mandatory overtime law. So you can't use the 25%, but based on wage staffing laws. It has to be with the ICU law in effect. So not only do you have to staff by the ICU law when you're staffing on a regular daily basis now, but also if you come and tell the Department of Public Health that you have the bed availability, you have to show that you have the staffing of those beds available based on the ICU and mandatory overtime laws as well. Yeah, furloughed, the famous word that we don't have in our collective bargaining agreements per se, which, anyways, people who were let go and shouldn't have been let go, which I know there's a lot of grievances on that matter now for the whole process and everything. But in the actual criteria that was set up, the guidance from the Department of Public Health, one of the things they did say is that they would want the furloughed workers returned to the extent possible prior to presumption of elective cases. It's not as strong as the language I would like to see, but nonetheless, it's making very clear that if you're going to start business as usual, then the expectation is that workers start to be brought back if they were laid off for COVID reasons. That's kind of a twofold question. The Department of Public Health, obviously, under Health and Human Services, is overseeing it, but the mechanism that they set up for sort of a general oversight is really a governance structure that has to be set up by the criteria written under the guidance, requires that there be a governance set up to oversee this, and that governance structure is set up within the institution, which either can be done at an institutional level, or if you're part of a system, it can be done at a system level. But either way it's done for governance and oversight, it has to include labor. So your bargaining units, whether they're individual or grouped together doing a system, you have to be seated as part of this governance structure on the oversight of restarting and normalizing operations. Well, in order to open up, the way this works is that once you have the governance structure and all these criteria met, the CEO of the institution or the system is supposed to sign an attestation form to the Department of Public Health saying that all these criteria have been met. Once that's done, then they can proceed as per the outlines on the restarting of the guidance. If it turns out that there's a surge of COVID patients and you no longer have that 25% bed capacity, or you can't meet, you don't have 14 days of PPE on hand anymore, you lost your replenishment supply, or you can't staff by the ICU anymore because, nurses got sick and you don't have adequate staffing, whatever it is that you cannot meet anymore under the attestation, you are supposed to notify Department of Public Health and then back off any of your elective cases until such time as the criteria can be remet. When it can be remet, you're supposed to then re-notify DPH, and then you can resume back to normalized operations again. So the attestation form is sort of I sign my name here and I attest that this is truthful, that we've met this criteria. The data on the bed availability is going to be up apparently on the Department of Public Health or Health and Human Services website, on the COVID website for bed availability. So you should be able to monitor if these institutions are saying that they have the bed capacity or not. Having said all of this, and there's supposed to be an attestation form, and labor's supposed to be on the governance grouping for the reopening criteria, and there's supposed to be transparency with these numbers available through the Department of Public Health or through HHS, however they're going to do it on the website. You're going to know better than anybody whether or not somebody's playing hinky with these numbers. If you see that the staffing is outside of the ICU staffing, or the mandatory overtime is being used inconsistent with the law. If you see that there are cases that are being done that are inappropriate based on staffing, all of that, if that's the case, they're supposed to notify DPH that they're no longer able to follow and back off elective, but that's not being done. I would raise the issue inside the building, of course. You have unsafe staffing forms, you have those forms, you should raise it, and you should raise it through your union voice and demand that they follow the criteria that they've set out. If you're finding that they are tone deaf as well, though, do not be afraid to go ahead and notify the Department of Public Health as well that the numbers that are being portrayed in the attestation form is no longer truthful, because we will want to be all over these institutions. If they're not, we're going to find that there's a resurgence inside of these buildings, and that is not going to be good for anyone, not the patients, not the people taking care of the patients, not the visitors, the food that come in. It's not going to be good for anybody. So it's important that, since this is a sort of a self-governance structure that they're creating, if it's not working, if you don't raise a flag on it, then it's not going to work for anybody. So obviously, things are opening up now in the public, and I don't think it's going to be a surprise to everybody over this Memorial Day weekend. I certainly was out and about going for a jog, and I had my mask on, but I was trying to take a look around me as people were gathering to see, how much are people really following this? And I don't think it's unusual for where I live, but we're definitely seeing probably anywhere to a third of the people not doing masks, at least in my town. There seem to be a younger population that's not wearing masks. That's unfortunate. I do think that we've now seen that the younger population is just as exposed to this virus as everybody. It was a little bit delayed or latent in terms of seeing what the symptomology would be, but just as with adults, there's going to be a small population of folks who get really, really sick. We saw the write-up of the Kawasaki syndrome and some other things that went on with the kids. So if there was ever a reason for parents to be really clear, no, everybody needs to be following this. I think we're going to have to make sure that that gets done. If not, just as we saw the early signs of the virus in Massachusetts in February, the actual peak that we saw was in April. So if you look at 2.5 months at a time when people really weren't clamping down in the beginning of March or whatever. So let's assume that half plus the population is clamping down, doing social distancing. Certain other populations already had the virus. Nonetheless, if certain population isn't following it, clustering and sharing the virus among between each other, we're still going to see an uptick. And that uptick is likely going to be seen in about 3 months, which again is the concern that we talked about earlier, because that will get us into the fall, when we can expect the schools to be opening up, and we can also expect that we'll be facing influenza as well. So I really think, I guess we all are really going to have to, and I've seen so many nurses doing this on social media, and I really appreciate it, talking to friends and family and trying to give them a sense that while a lot of people really won't be that affected by this virus, there's a small fraction of the population that will be very affected. And if we don't want that to be someone's mother, father, sister, brother, or child affected as well, then we really do need to do everything possible we can to try to prevent the spread until we see a vaccine, which could be quite some time, or at least that we can have the pace of the virus such that we have the best chance of caring for the few folks that aren't affected. And in fairness to the other populations of people who have been waiting for a long, long time now to have certain procedures done, that haven't been able to because of reluctance to go into the hospital. A lot of COVID patients were at the surgery. If we do this part really, really well, then we can do it well right through the fall. If we don't do it well and we have a surge, we're going to be facing again another clampdown, in which people are going to be down into a shelter in place or stay at home again. And I don't think that there's a real strong desire to want to do that. And I certainly don't think that people who are trying to get back to work in the economy want to see that. So getting back to work and the economy and keeping people safe and healthy really comes down to every one of us just doing what we're supposed to: washing hands, wearing masks, and staying 6 feet apart. And I don't think that's too much to ask. So I ask all my colleagues to just keep pushing as hard as you can to make sure that people do it. And to that note, I don't want to let this moment pass without extending my sympathies and condolences. We have lost at least 2 members at this point to the COVID virus. One was admitted in the Women's Hospital, another nurse last week, Steve Merrimack down at the hospital. It's difficult to see everybody pass. It's even hard, I know, on our colleagues to watch a colleague pass. It's a serious issue, and I'm not quite sure everybody on the outside world understands how serious it is, but I know that you guys see it every day. And I also would mention, as people are starting to go back to their regular units, there was nothing normal about this, and you are going to have some difficult times going back to your regular units. You were upended, and you worked with people you didn't work with before, you worked in a situation you didn't work in before. And now going back to your unit, sort of expected to try to pick up like you never left off, is completely unrealistic. So don't think that it should be. And if you need help and you need to talk to somebody, make sure that you let folks know inside your building. We're trying to make as many people available as we can to be able to help people talk through it. But yeah, this is going to stick with you, and it's not over yet. So, manage yourself as well. You're entitled to it, and you have to know that there's nothing normal about this. So very much appreciate everything everybody's doing. And again, if there's anything that you see that we need to get out for information or to help you with, you need only contact your own rep and whatever information resources or whatever that we can make available to you, and make sure that we know. So thank you, and I guess I'll see you next week.